Welcome to TMA's Myositis Research Insights. My name is David Mochel. I'm the past board chair, or past immediate, I should say, board chair of TMA's Board of Directors. This webinar series is designed to connect patients and their families to specific myositis researchers in our community. Before we get started, please note that this webinar is being recorded and will be available on TMA's YouTube channel on August 1st. Please put any questions you would have in the Q&A box of the bottom of your screen, and we'll get to those at the end of the Dr. Oldroyd's presentation. We're pleased to discuss the research of Dr. Alexander Oldroyd. Dr. Oldroyd completed his medical degree and master's in scientific statistics at Lancaster University. He has since completed an integrated clinical and research training program through the Academic Foundation Program and NIHR Academic Clinical Fellowship. In 2021, he completed his PhD at the University of Manchester. His PhD focused on the development of a novel remote disease severity measurement techniques, which included remote gait pattern measurement, specifically focused on idiopathic inflammatory myopathies. So I'm sure you can explain that better than I just did, Dr. Oldroyd, and thank you very much for being here.
Great. Well, thanks so much for having me and allowing me to present to you all. So I want to start by thanking the TMA for funding the fellowship that I was awarded to take this research further forward. It's a really important area that I hope you'll all agree is important and could have an impact on research knowledge and also the clinical care of patients with myositis within the years to come. Now, this is quite a big area, and if I wanted to go through absolutely everything, I'd need many hours to go through all this. So what I'm going to do is I'm going to present some of the highlights, some of the reasoning why I've done this research, some of the relevant findings, and then talk a little bit about some of the future directions. Then I want to leave lots of time so I can answer lots of questions as well. So please tell me if my slides don't work at any point, and we'll crack on. So I'm going to focus on daily symptom monitoring today. So if we take Mrs. Smith, so she's a typical patient that we see. She's 48 years old. She was diagnosed with myositis around 3 years ago, and she's responding really well to treatment. She's on methotrexate by itself. She's off steroids, which is great. And she comes to specialist clinic every 6 months, and a lot of patients may see their specialist every 6 months. They may see them less frequently, but they'll see them on a regular basis, and it's probably a scheduled appointment. Now, Mrs. Smith, she comes, she says, I'm usually fine. I just carry on. I never make much of a fuss at the appointments. I know the doctors are busy anyway. Says that she has some up and down days. Her tiredness, she can't predict when it's going to happen. And she says sometimes it's tricky to carry the shopping, but she doesn't let it beat her. Now, if we think, so Mrs. Smith, as I said, she comes to clinic every 6 months. So the only time that we actually collect any clinical data on her is on those 2 clinic appointments, those 2 days a year. That's 0.5% of the whole year. We don't know what happens the rest of the time. So there's 363 non-assessed days in the year. And, I'm sure you'd all agree it's plausible that collecting data more frequently may enhance Mrs. Smith's care. It may allow her and her doctor to make more clinical decisions that's focused on her care and what's affecting her. So there are some potential solutions to how we could collect data more frequently. Firstly, walking pattern. So we know that many patients with myositis, their walking pattern is affected. And we are able to do gait assessment at the moment in gait labs, but this is all quite expensive. You need to be in a specialist setting. You need specialists to interpret it. And you can only do it in a single snapshot. But there are some technologies that have developed recently where people can wear sensors that can remotely and continuously measure the walking pattern as well. And then another potential solution in which we could carry out more frequent data collection is on patient symptoms. Now, we collect patient symptoms whenever we see them in clinic, but as you know, you have to be in clinic to do that. But now there's the capability of collecting symptom data via devices such as smartphones, which almost everyone has now. And both of these together could enable continuous monitoring outside the confines of the clinic. So the aim of this project was to see, well, can daily symptom data provide extra useful information to allow us to assess the disease activity of myositis? And I'm going to talk a little bit about the study. So we are carrying out some further data collection at the moment, and all of these results aren't available, but all of the results I'm going to present illustrate some of the utility on an individual patient basis. So this was the MyoPAD study that we did. We're currently doing the MyoPAD 2 study. So we recruited adults with myositis. They were in the study for 91 days. We assessed them in detail at the start and end of the study. The rest of the time, they completed symptom data entry every day via a smartphone-based app. And they also continuously wore a gait pattern sensor as well. So for example, so we collected a number of different symptoms, including pain, myalgia, fatigue, mood, and also weakness. And we collected these on a 0 to 100 scale. So 0 was where there was no pain or no weakness. 100 was where there was maximal pain, maximal weakness as well. So I will mention, so at the start and end of the study, we collected what's called the IMAX core set measures. Some of you may be familiar with this, and I will take a moment to explain what it is actually. So this is a method that lots of researchers have come up with where we can quantify the disease activity, so how active someone's myositis is. And there are 6 different things we collect. So the patient global, so usually a 0 to 10 scale, the physician global, 0 to 10, the HAQ, which is the health assessment questionnaire. So this is the higher the score you get, the greater the functional impact of myositis is. The manual muscle testing, so this is where we test the strength in lots of different muscle groups. A damage visual analog scale, so this is where we assess, well, how much irreversible damage has actually occurred. And then the CK, which is a muscle enzyme. So just to mention something about engagement. So this is how well people actually engaged with the data collection. So over the 91-day period in 21 participants, we collected 22,880 patient-reported outcomes. This is huge. Normally in studies, we only collect this at the start and end of the study, but every day we were able to collect a huge amount of data, and 88% was completed, which was great. And then the sensor data, we collected 42,308 hours of sensor data, 93% completion, which was great. I suspect in the MyoPAD 2 study, this may be a little bit lower because it's in a real-world cohort over a longer period of time, but we'll see. And this is reflective of lots of other similar studies. People engage really well with these studies. And I'm going to just focus here on this one patient. So you can see at the top left and the top right, the IMAX core set measures. So at the top left, this is the IMAX core set measures at the start of the study. So the physician global was quite low at 2. The patient global was very low at 1. The HAQ was relatively low at 0.873. The CK was just slightly high there, 480. And the MDAT, that's the damage VAS, that was pretty low at 2 out of 10. But then we can see at 3 months, there are some changes. So the physician global has gone from 2 to 6, it's increased. The patient global has gone from 1 to 4. The HEC has very slightly increased, but the CK is markedly increased from 480 to 1,200. And the damage VAS, that's remained the same. So if we saw someone in clinic like this, with these 2 core set measure values, we'd probably say, well, they have increasing disease activity, they're probably having a flare. But let's see how the daily symptom data actually gives us some more info on what's actually happening here. So each of these lines is a symptom. It's global activity, fatigue, myalgia, weakness, and overall pain. And we can see at the start they're all quite low, really. There's some variation, but they're all quite low. But something happens on day 50, and we can see the global activity, the fatigue, and the weakness all increasing. The pain and the myalgia, they remain low. But something happens on day 50. So we can actually see that, they have increasing weakness, fatigue, and global activity, and this starts on day 50. So we can actually pinpoint when the flare actually becomes symptomatic, and we can actually see what's happening here. And we haven't been able to do this before. We haven't been able to pinpoint the start of a flare. Normally, someone comes to clinic and they say, "Oh yeah, I've been really bad for 2 months," but that 2 month period, that within that 2 month period, people develop irreversible damage. We can reverse the active inflammatory component, but we can't reverse the damage. So this approach potentially allows us to remotely identify the very start of a flare and instigate treatments earlier to prevent the damage occurring. So we then took all of the data and did some analysis on this, and we actually, for the very first time, investigated what flares actually look like in patients, because patients tell us a lot about flares, and everyone means something slightly different, but we wanted to actually quantify it using this quantifiable data. We did a lot in the study. I'm not going to go into absolutely everything, but this is how we defined a study, and this was defined with a lot of patient input. So patients told us repeatedly that flares are pretty short. They last 2 or 3 days, really. And they define a flare as being a marked increase in severity of a certain symptom. So the red line, this is a representation of a flare in one person. So you can see on day 24, this is the weakness in red. The weakness score is quite low, remains low on day 25, day 26, day 27, but then on day 28, it shoots up. So we could say, well, this is the start of a flare on day 28, and this is the peak, because after that, it reduces back down. And then when it goes back down to the baseline on day 31, this is the end. So the duration of this flare was 3 days. So we used an algorithm to identify every time this sort of pattern happens within our cohort. And we then had a look across all the different symptoms and wanted to characterize how often these flares occur, the severity of them, which ones occur most frequently, which ones occur least frequently. And I'm not going to describe everything in this table. You can see just the take-home messages at the bottom there. So fatigue flares were the most common. So a sudden short period of days where the fatigue is suddenly worse, that was the most common. Myalgia, which is specific muscle weakness, that was the least common, but they still happen quite frequently. And flares typically lasted for about 3 days. So a flare would occur, and then after the 3rd day, it would resolve. Interestingly, fatigue flares lasted slightly shorter for 2 days. We don't quite know why, but that's what we found in our cohort. And they were quite common, really. So this column here, we can see incidence rate per 100 person days. So what this means is, if you take one person, follow them over 100 days, you might expect 23 flares of fatigue or 18 flares of weakness. Now, these might all coincide alongside each other, but this is quite frequent. This isn't something that's happening once every 6 months. This is happening multiple times in a 100-day period. We also then took a step back and spoke in detail to a lot of the patients about what they thought flares were and some of their reflections on how we measure disease activity at the moment. And you're very welcome to go and read this paper, but here are some of the take-home messages at the bottom. So again, fatigue was the most common symptom. Pain was very common as well. And people said they had good and bad days. They'd have a few good days and then a few bad days. They couldn't predict when they'd happen. And also, people also told us a lot about how the CK measurements, so the blood test and the manual muscle testing, it just didn't tell the full story for them. They felt that it represented, what the disease how active the disease was, but it didn't reflect on how it was affecting them. It didn't reflect on the frequency. It didn't impact and reflect on how it was impacting their function on a day-to-day basis as well. So we have some future directions, which I've already mentioned. So the idea is that we're going to integrate this into clinical care. Now, it takes a long time to actually integrate something like this into clinical care. Taking a step back, we've been basically using the same model of medicine as we have for about 100 years. Patients come in on a scheduled appointment, we assess them, we make a decision then, they go home, we don't see them again until the next scheduled appointment. Using a continuously monitoring remote approach is completely different and has a lot of impacts on clinical care, funding, patient care as well. And also being reactive to changes in disease activity that we detect remotely is also going to have an impact on clinical care. Usually, the only way we actually react to clinical care is when a patient tells us that something's changing, and then if we can fit them in, we might see them again. But changing to more of a reactive approach, where patients can be alerted, well, clinicians and patients can be alerted to a change in symptoms that maybe they aren't even aware of, then having a detailed assessment in a timely manner and changing treatment appropriately is going to change a lot in clinical care. It's going to take a lot to actually bring that into fruition. And possible early flare detection as well. So as I mentioned, flares may look different in different people, and they may be due to different things. Someone may be having a flare because they've recently reduced their prednisolone dose. Someone may be having a flare because their disease activity is suddenly increasing. And being able to identify a flare really early, ensuring that when we do change treatment in response to this, that the treatment is beneficial and not actually causing undue harm, is going to be really important to assess. So that's in a nutshell everything that we've done on this. As I say, we're collecting data at the moment on the MyoPAD 2 study. I'm looking forward to sharing results of that. But I'd like to say again, thank you to the TMA for supporting my research. It's been really useful being dialed in and having contact with lots of people in many different countries as well, and patient groups as well. So I'm looking forward to continuing the relationship with the TMA, and I look forward to sharing some future results with you as well when they're available. Thank you. I'm more than happy to take questions on anything I've spoken about. I'm more than happy to clarify anything I've spoken about or to talk around this subject as well. So thank you.
No, thank you. And I'll get to the questions in a second. I think for our audience, like when you have I mean, this is so practical. Dr. Oldroyd, I mean, this is very pragmatic. I think what you can say is, in general, in the world, there are clinicians. I was a clinician. I was an orthopedic surgeon, did pretty minimal research. There's researchers, who really focus on their research. And then there is a special category, and I think it's people who are clinicians and researchers. And I would say that that group in particular is really to be commended, because to be able to do both of those things really is something, and you really can get a good feel for the, fruit of your labor. I think you brought up it's a good slide. I hadn't seen that before, but it really, when you see someone twice a year, you are getting a snapshot, and as a clinician trying to dial through I did hip and knee replacement. So you're looking at the husband, I'm looking at the spouse, I'm trying to get, and I find this when I would go see the docs wherever, I would tend to minimize my symptoms. How you doing? You're doing fine. Now I had IBM, it came on slowly, you adapt. It's a different disease, and some of your questions we'll get to in a sec. Talk about what cohorts were you studying. But I would say what this does is provide a very accurate picture, of certain things. And the fatigue, very interesting. I would not have thought that there would be that many flares in a 90-day period. I mean, you're talking like every 5 days. Very interesting. Yeah. So anyway, let me get to the questions. So part of this is some very good questions. So I'll just start at the top. Jane writes, is the MyoPAD 2 study still recruiting participants?
Yeah. We're doing the MyoPAD 2 study in Salford Royal Hospital in the UK at the moment. So once we've done the MyoPAD 2 study there, we're going to expand it as well. We're doing this in a iterative process. So because we want to do it correctly, that may take longer, but we want to do it all correctly. So Jane, if you are affiliated with Salford Royal, I don't know where you're based, then you're more than welcome to contact us. But if not, then hopefully in future we'll be opening the study to your site, wherever that is.
United States.
Okay.
Yeah.
Okay.
Yeah, US. So question I had, I'll jump down a couple here. So of your, just a rough pie chart. So what forms of myositis were included in this, and did you have a pie chart? Maybe I missed it. I apologize, but
I
kind of
didn't.
a, yeah, I'm sure you have it somewhere, but just a
Yeah.
ballpark of,
So
yeah, what are we talking about?
off the top of my head, we had a mixture of people with dermatomyositis, antisynthetase syndrome, and polymyositis. We didn't include inclusion body myositis.
Did
Uh,
not.
no, we didn't. We
Yeah,
didn't.
makes
But
sense.
that is a future area. So obviously, I don't want to go into too much detail, but obviously the symptom pattern and disease trajectory is very different in IBM. So I definitely think that daily symptom monitoring has a role in IBM, but I think that the relationship between flares and symptoms is probably different. But that's definitely a future area of research.
Yeah, I think I know what your lines would all be pretty horizontal. I mean, they'd be
Well,
low and they'd be
what is
very
there?
horizontal. Yeah.
But this is the thing. So I've gone into this with no preconceived ideas because there's a lot of received wisdom in myositis,
Yeah.
where we say, oh, flares don't happen often. The symptoms only change very slowly. This all these sort of things. But actually, when we actually look, this is the only study that's actually taken detailed patient data on a daily basis, and we actually see something slightly different.
Yeah,
And
I'm
this,
speaking just from the world of IBM. Yeah, I mean,
yeah.
yeah.
And
Yeah.
this is because, as you said, patients just they don't convey exactly what may be happening to them. And a lot of the time, it's very difficult to remember. So if someone said to me, "How did you feel 6 weeks ago?" I probably wouldn't be able to
Yeah.
give an accurate answer. But we expect patients to do this. But actually, one interesting thing we find is in the clinic, when we look at this data with the patients, we say, "Oh, what happened there? There was a bit of a
Yeah.
blip in your symptoms." And they say, "Oh, I don't remember that." And they'll say, "Wait, that was when I had to miss my methotrexate or steroids for a few days because I had an infection." And say, "Oh yeah, well, obviously, we can see that your symptoms changed there." And they said, "Oh yeah, I wouldn't have remembered that."
Yeah, no, absolutely. And I think for those sort of patients, this could be incredibly helpful. So how many participants were in the MyoPAD 2? Is the cohort the same as MyoPAD 1?
So we're still recruiting in MyoPAD 2. So once we have all the results and everything, so we're aiming to recruit 100. So once we
Yeah,
have
for
all of,
MyoPAD 2.
yeah, once we have all of the results and everything, I'm more than happy to share them.
Good question from Martha. Were the flare, and I'm sure this is patient specific, were the flares treated? Right.
Yeah,
It's a great question.
great question. So so all the data I presented, we only analyzed the data after all of the data collection. So this wasn't an interventional study. We weren't trying to identify flares to then instigate treatment, because that takes it to a whole new level. So
Mhm.
if we were to identify a flare, obviously the plausible thing is to then say, well, we need to treat it. And I suspect the hypothesis would be that this would lead to better outcomes. But there is obviously the potential that it could lead to some adverse outcomes. It could lead to increased steroid use, which has some side effects. It could lead to inappropriate escalation of treatment. And these are all of these really detailed, nuanced things that we need to look at in
Mhm.
detail to make sure that we're intervening safely.
Yeah, because you're getting data now that you didn't have before.
Exactly.
It's
Exactly.
yeah. Like when I started orthopedic, MRIs were just starting to get popular for knees, let's say in the early 1990s. I was just going to say. So all of a sudden we were finding all these meniscus tears that we didn't know, and it was okay,
Exactly.
and so we're operating on all these meniscus tears because the MRI showed it, and maybe that wasn't the right thing to do. So it's
Exactly.
data points we did not get before, and all of a sudden we didn't know, we were, how to learn how to use the technology. Another very good question. Do you think that this approach could yield endpoints that could help get drugs or other treatments approved?
Definitely, definitely. So we see that. So this approach has been used in some other conditions. So um, rheumatoid arthritis, for example. And what it does is it doesn't replace the traditional endpoints, it complements them. So you're able to identify exactly when the treatment starts to work. So say you have a study where you assess people every 3 months, you can identify where on those 3 month scales it starts to work. But with daily symptom data, you can identify exactly when it starts to work. You can identify those people where it works early. You can identify those people where it works late. But equally, if say the primary endpoints aren't met, so the IMAX core set measures don't demonstrably change, but we show that there's a substantial and significant change in fatigue and pain and perceived function, that could go some way to identify the utility of a drug.
Yeah. Off topic, but somewhat relevant. What is your impression, just as a researcher, with the IMAX core measure set?
So I think they're great. I think they are relatively easy to use. I think they're comprehensive. The difficult thing is that it's difficult to bring them together. It would be so we have the total improvement score, where you can enter the changes of the IMAX core set measures, and it gives you a score on how much they've changed. But I think it'd be really nice if you could distill all of the IMAX core set measures into a single score. But like every measurement, they're imperfect, and there's a lot of inter-rater dependency as well. So when I measure someone's strength, someone else will get something slightly different as well. And that's particularly why I'm so keen to develop this sort of method. Another thing that doesn't try to make the IMAX core set measurement better, it just complements it and gives a completely different viewpoint on the patient journey.
Interesting. Thank you. Does the data collected in these studies constitute what's called PROs, or patient-reported outcomes, or
It
not?
does. It
Yeah.
does, yes. Yeah, it does.
And then I guess interesting, and once again, this is interesting with a correlation between flares and exercise. Were you able, this would be anecdotal, right? Because it would come down to every patient is different. But in these, as you discussed the results with the patients, did you notice any particular correlation, or causation, I'd say, or
Yeah.
correlation even with flares and exercise?
Yeah, so we didn't investigate the link between flares and exercise in a quantifiable way in this study, but it's definitely a really intriguing area to investigate in future. So thanks for that. Talking to the patients in the interviews, there were some patients who said that whenever they physically exert themselves, the next day that's when they have a bad day, and these are the patients who may have limited muscle function due to either active inflammation or damage. So, this is the whole thing. So, we all use the term flares, but everyone means something slightly different. When you talk to a lot of people, someone would say a flare is a temporary increase in symptoms, but there's lots of different things that can cause that. And this leads on to the suggestion that there are lots of different types of flares. So there might be a flare that's due to active disease. There might be a flare that's due to treatment reduction, which may be appropriate. There may be a flare that's due to overuse of muscle, which then leads to a heightening of symptoms. There are lots of, I think there's going to be actually lots of different flares when we actually drill down to it. And when we have enough data, we'll actually hopefully be able to identify flare subtypes.
Yeah, interesting. No, appreciated. I would say from another attendee, I have IBM and had a rapid change in symptoms, which I would say is unusual for IBM. So, but it can happen. I think Dr. Oldroyd's comments about not knowing or assuming is right on. I'm on IVIG, and there's a strong correlation with CK and progression. My CK is lower than it's been in 8 years, and my quality of life has improved. So I think the more of a comment than a question. I would just say off the top of the head, or off the top of my head, it makes me wonder if there's something else on here going on other than just pure IBM. This doesn't sound typical for IBM, but I guess if you've lived in the myositis more long enough, it certainly can. Glad to see that you're improving with IVIG, but traditionally, straightforward sporadic IBM has not responded to IVIG therapy. I don't know if that's your impression, Dr. Oldroyd.
Yeah. I agree too. But I think I think it's interesting where, we could use daily patient-reported outcomes to quantify and record a change in symptoms once we instigate a new treatment, on, whatever that is.
Yeah. No, I think, as I think Jane pointed out in the chat, real-time data monitoring has been a significant, I say, game changer advancement in other diseases such as Parkinson's and Duchenne. So I mean, when I look at this, I'm like, this is very simple, pragmatic, and can give you a very nice feel for where things are going. No, it's very.
Yeah.
So a question of, is anyone doing work like this with advanced use of technology and remote symptom monitoring in the US or Australia that you're aware of?
Australia, no. In the US, I don't know the details, but I think Rohit Agarwal and some of his group in Pittsburgh, I think they're looking into the use of devices like Fitbits.
Yeah.
Um, so, which is slightly different to gait monitoring and daily symptom monitoring as well. What I would say, so populations are different. The way that people experience symptoms are different in any disease, and the way that people interact with the healthcare system is different. So findings that we might find in a UK population
Mhm.
may well be very similar to a US and Australian cohort, but there will be some subtle differences. We see the perception of symptoms is very different across different cultures as well. So when hopefully, if this sort of technology is used more routinely in future, it would have to be tailored to the patient cohort and the healthcare system and cultural variations too.
Yeah. Thank you. And also one comment in the chat that manual muscle testing does not always correlate with quality of life. Would completely agree with that.
Yeah.
What's
Oh yeah.
interesting, and back to my comment about IBM, I'm thinking that line's going to be fairly, fairly flat, and that they don't change, at least that's just personal observation, just people I've known. What's very interesting is my wife always, who was a neurointensive care nurse, always felt I would sometimes go in stages, like I would have a quote unquote flare, but then I said, well, why do you say that? Because I felt it was more of a gradual progression. She says, well, I noticed that, you did this and this. And what was interesting is usually her observation was based on, I could get out of that chair 2 months ago and I couldn't get out of that chair now. That was her observation but I can just tell you, I could feel it coming on in those 2 months. I knew it was harder and harder to get out of said chair. All she saw was that I was getting out of that chair 2 months ago and now I can't.
Okay.
So
She was seeing the step changes.
she was seeing step changes, right? So and this is a very good smart observer, but I knew it was coming, so that's interesting. So it's interesting. So, and once again, my IBM may be very different than other people's IBM. So but all the more reason where this sort of data collection, real-time data monitoring is just would be fantastic, and it's another fantastic piece of information. Couple last, and I have Kimberly. I've not forgot about your POTS question. I'm saving that one for the end. So it's a little off topic. It's a good question. Do we expect this technology to become widely used to assess symptoms and progression? It's a good question.
Good question. So I hope so, but do I expect it? I think it's going to take a long time, if I'm being honest. Medicine changes slowly, and this sort of approach, so that you'll read articles where they say AI is going to change medicine and it's going to be a magic bullet, and everyone's disappointed because it doesn't. And that's not what medicine's like. Medicine isn't about making everything dramatically different overnight. It's about making those incremental gains, that 1 or 2% over years. And I think that this is the sort of technology that's going to help 1 or 2%, and it's going to take years. And I think so. Hopefully, in decades, we'll look back and we'll say, why didn't we do symptom monitoring? It was so simple. Actually, it's tricky to get it into the workplace. It's tricky to get everyone used to it and change the way of working. And it's not necessarily going to make our jobs easier on a day-to-day basis. There's going to be more data, there's more to analyze, but it'll mean that patients have better outcomes. That means that we're needing to intervene less. That means that our patients need to come less frequently, and patients have a better quality of life. So I look forward to the day when we're able to just monitor people remotely and, pick up the phone in 6 months and say, hello, Mrs. Smith. I've been having a look at all your data and it looks like everything's doing well. And she'll say, yeah, I'm feeling great. I say, great. Well, we don't need to see you in clinic then.
Yeah.
But we'll see.
Well, and along these lines, in preparing for visits, on the TMA website, I think it was Tom Lloyd who came up with it. There's something called the Myositis tracker. You know what I mean? It's something, it's basically, you can just type in Myositis tracker, TMA, you'll find it. It's almost like a nice checklist, to be honest with you, that you can go down to get you thinking about, what do you need to convey to your physician? I think
Yeah.
that's what, when you're sitting in front of them, we all know you have what, depending where you go, you've got 5 minutes, 10 minutes, whatever, you tend, at least a lot of people tend to spin the positive. And it's important to it's important on the doc too, to try to pull out some of these things. That's where I got better at asking questions year 20 as an orthopedic surgeon than I did year 2. But I would look at that as something to jog your memory. Listen, you can go through the list. My dysphagia is fine. This is fine. Breathing, lungs, et cetera, et cetera. Anyway, so I would say that's something to consider kind of prepping for the visits. Last, as I did notes about Apple Watches, other Fitbits, interesting, the wearable technology. We heard about this, to your point, Alex, in cardiology, it was going to change the world. 10, 15 years into it, it's great for AFib. Okay, it's great for atrial fibrillation. They've got a nice portable EKG, but outside of that, the wearable technology hasn't dramatically changed a lot of the other cardiovascular diseases. It's getting there. It's incremental progress. All right, so this is a little off topic, but a good question. Have you, more of as a clinician, have you seen post-COVID POTS with autoimmune diseases? And if so, any recommendations for recovery? And that's basically postural. Well, you can explain it. Sorry, go ahead, Alex.
Sure. So, have I seen POTS? So I've seen a lot of patients who have myositis who also develop COVID, like many of us have. And some patients say that they have had a worsening of their symptoms temporarily, and some patients have had a worsening of their symptoms permanently. And then there's obviously the link to long-term effects of COVID. So some patients have, this long COVID. And what I would say is it's really important to ensure that patients are treated for exactly what they have. So I see a lot of patients who have myositis and they're also given a label of fibromyalgia or POTS or something else. And I always say to patients, fibromyalgia is a real thing, POTS is a real thing, but I think it's overdiagnosed. And I think that if you have myositis and you're developing other symptoms like POTS or fibromyalgia, it's really important to make sure there's nothing else going on. It's really important to make sure that there isn't because patients have myocarditis with COVID. Has someone who has myositis, who's predisposed to autoimmunity, then develops COVID, have they developed myocarditis, which leads to this, rather than being labeled as POTS. So I would say that probably the best thing you can do in terms of recovery is to have a very clear and quantified diagnosis. That's what I'd say.
Yeah, that's an excellent answer. The CAR T cell therapy comes up all the time. I would say we can let me do that in a second. I think so. To this question about being able to track on our own. A couple of simple, the question is, should we be able to track on our own somehow daily? Then we can share with our physicians, helps all of us. Can you share something that we could all use? I would say the Myositis tracker, which Linda, I believe, just posted a link in the chat, at least is a good document that at least covers all the bases. Reviewing that, that you could look at. It depends on probably how active you are. As someone sitting in a power chair right now, I know that this thing goes 1.2 miles a day on average, unless I'm out of town. But I'm just saying is so. But I think I did see someone in the chats, who does use an Apple Watch and can track their steps and those sort of things. So there are very simple things that you can use. So I think it depends on your stage. If you're ambulatory, if you are out, there's a bunch of Apple Watches, Fitbits, trackers, even your step app in your iPhone, which is somewhat accurate, can be helpful. If you're not as mobile, there are other things that you can do. I don't know. I think there's anything else you could add to that, Alex?
I don't think so. I think once we actually get these technologies once we define their clinical utility,
Yeah.
then we can actually translate them into clinical practice.
No, appreciate it. And seeing your data points was fascinating, actually. That was really just looking at those data points for the people with those flares.
Yeah.
All right, comes up all the time. Don't know if this is off topic. Not sure. It's not super relevant to this, but I guess, you
I'm
know, in
happy
an
to talk
effort,
about CAR T. Yeah.
fire away.
So so CAR T is one of these potential magic bullets, just like AI and other things like that. I think it's certainly going to have a big role over the next few years. The big question is, who is it going to be appropriate for? Is it going to be appropriate to use this at the time of diagnosis to prevent any treatment being required at all? Are we only going to use it for patients who are refractory? How many of our patients are actually going to be able to safely have it? Because having CAR T, it's a big undertaking. So there's a lot of unanswered questions, but it's very promising. The cost is huge. And a lot of people say, well, you know, we can never use CAR T because the cost is so huge. But I would say, you know, surely the cost of CAR T is much, much smaller than someone being economically inactive because of active disease, having to go to the hospital every 6 months, having to have lots of treatments, having complications, hospital admissions. I'd also say have a look into, there's another fascinating new drug. They're called bispecific T-cell engagers, or BiTEs, BiTEs. And these basically do what rituximab and CAR T do, but you don't need all of the pre-treatment that comes with CAR T. So definitely, I think that's another promising area.
Appreciate it. Okay, I'm gonna finish up here. Appreciate everybody. I would say thank you very much to Dr. Oldroyd for the work you were doing in the myositis community. This is fascinating. It's nice to see the results of grants sitting on the board and approving these things, and the data points are fascinating. And we certainly look forward to hearing your progress in the future. Thank you to the audience joining us today. Please join us Thursday, July 11th. So this Thursday at 4 p.m. Eastern Time for a program that invites the whole community to rally together to help veterans with IBM. Find out what simple steps you can take to help veterans with IBM get the care they need from the Veterans Administration. Advocates from our military veterans with myositis affinity group have been very hard at work making progress and are turning to the myositis community for support. In this empowerment clinic, we'll discuss their efforts and have a special screening of a newly released documentary, Not the Life We Wanted, an inclusion body myositis documentary. This is excellent viewing for anyone who wants to understand more about IBM or share information about IBM with their family and friends, as it explains the everyday challenges that everyone with IBM faces or potentially will face. You can register for this special program on our website at www.myositis.org, and the registration link should be in the chat box. Once again, thank you, especially to Dr. Oldroyd for its dinner time, I believe, in the UK. I did like the Lego. Pictures and the Lego animation. Yeah, quite good. I'm gonna have to find out where you got the Lego animation.
Definitely.
But very nice. Thanks again, and everyone enjoy the rest of your day and evening. Have a nice day.
Thanks for having me. Bye now.